The AAOS Bone Beat Orthopedic Podcast channel is pleased to welcome you to the latest episode of the AAOS Now podcast. This monthly podcast series covers a broad range of topics to help orthopedic surgeons stay informed, enhance their practices, and provide the best possible care for their patients.
Hello and welcome everyone. I'm Ahmed Emara, and I'll be your host for this episode of the AAOS Now podcast. Today we'll focus on heroic interventions in orthopedic surgery, and today's guest is Dr. Nathan Mesko from the Cleveland Clinic. Dr. Mesko is a distinguished orthopedic oncologist. He is the Vice Chair of Global Clinical Operations for Orthopedic Surgery and the Center Director for Orthopedic Oncology at the Cleveland Clinic. Dr. Mesko holds dual professorship appointments in the Department of Orthopedic Surgery and Hem-Onc. Welcome to the podcast, Dr. Mesko, and thank you for being here. As I'm sure most of the audience knows, modern orthopedic surgery has become extraordinarily capable. Today we have a varied spectrum of solutions that offer a chance at limb salvage and functional preservation for pathologies that previously were deemed unaddressable. So before we talk about the when or the why of heroic interventions in orthopedic surgery, I feel we should start with something more fundamental. So, Dr. Mesko, when you hear the phrase heroic measures in orthopedic surgery, what does it really mean to you?
Yeah, I think it's a great question. And I think ultimately, heroic, as we mature in thought processes, certainly as I've matured in my thought process, I'm 13 years into this experiment of doing bad cancer surgery, infection surgery, and failed joints, is that heroic isn't necessarily how difficult the surgery is. Heroic's actually, what am I asking this patient to endure in order for me to possibly get them to the outcome that I have envisioned? And I think it's defined in the actual context of that individual, what we're attempting to do. And in many ways, our capabilities should be outpaced by our wisdom. What do I mean by that? The questions that we start to ask ourselves as we wrestle in this land of being heroic is, just because we can do it, should we do it? When in my world, we get these really awesome x-rays that are blasted all over social media, and we're very proud about it, and patients have unbelievable videos and what the human body is able to adapt to with these custom reconstructions and coming back from multiply revised infections and these major limb salvage heroics. That is a snippet of what we see of that advertisement, and it doesn't talk about the entire story of what those patients went through. And I do think it's actually interesting, I alluded to this before, that the threshold of the heroic measures that we're willing to endure, I think, does change over a surgeon's career. Early on, you're just trying to prove to yourself that you're able to do this, you're courageous enough to do this, you're taking risks that are reasonable, and seeing if you can push that envelope, because in many senses life begins outside of its comfort zone. But later, as you kind of evolve and you see the mistakes you've made and you see the mistakes your mentors have made, and that's why we have fellowship and residency, you start to reflect on some of those patterns and patient stories, and it resonates in the recesses of your mind of trying to divorce that x-ray and that outcome from what that patient actually is able to tolerate. That, going back to that mantra of our capabilities should be outpaced by wisdom, that's the wisdom that you gain over the course of time.
We frequently see this multiply revised total knee patient who failed multiple two-stage revisions with a draining sinus, and this patient technically has a chance of limb salvage, but only a chance. So how would you help them decide whether pursuing that opportunity or chance at limb salvage is actually in their best interest? When is it worth pursuing that heroic measure?
Yeah. Not to get too tangential here, but if you look at what 4 things it takes to have a medical malpractice lawsuit be successful. We talk about negligence and standard of care, but one of those is actually informed consent. And in my world, as I know many of the orthopedic surgeons out there, our colleagues, our partners, that's a hard thing to wrestle with. If I have a patient in the office that I'm going to talk to about, let's just say, something simple like a proximal femoral replacement, that not to us, not that big of a deal, but how do I get them to understand that life will never ever be the same? Their abductors will never actually heal to this. They're always going to walk with a painless limb. And then let's start magnifying that by starting to throw in really maiming surgeries in an effort to help cure somebody. Sacrum, for instance. How do I get a patient to actually sign on the line that they understand that they're about to lose bowel function, bladder function, sexual function, possibly leg function, and this is permanent. It's never coming back. And this is going to be multiple weeks in the hospital and a pit stop in the rehab facility. That's a really, really difficult thing. And I don't know if giving up is the word, but there are certain moments in our careers where we truly cannot impart the gravity of the situation on a patient. So let's take a prosthetic joint infection, for instance, that has a fungal and gram-negative, all the poor prognostic indicators. And you look at a patient, you say, like, what is the scenario that we win? Now, my definition of win as a surgeon is different than that patient's definition of a win. In that patient's mind, this is a surgery, they're on antibiotics for a few weeks, and they go back to work. And how do you impart on them that we are one stop away from that horror dreaded word, the amputation, and that we really have to bunker down and wrestle with this? This is what it's going to take to maybe get you back to the reality that you have in your mind. I think it starts, and I know that we'll talk about this later as well, but pulling up a chair and listening. I think as surgeons, we are absolutely in this moment where we are trained to make a decision quickly. We're trained to be quick. We're trained to make money for hospitals and for our practices, and that means efficiency. And what happens is we forget about the listening part. And I think if we're going to have that, especially the gravity of a situation of should we be doing this even though we can, one of the most important things is to listen to what is the independence of this patient? How much pain are they in? What kind of family support do they have? How about job? What's the financial toxicity that's going to be linked to this? What is their reserve? Have I looked at the chart to look at their nutrition levels and all the things that I can do a beautiful surgery, but if there are many things that where their reserve tank is on empty, I can't get a wound to heal. What are we doing? And that's a really hard thing to take a surgeon and say, you need to take a moment and pretend just for a moment that you're a palliative medicine doctor or you're a psychologist or to sit there and listen. And I think if we did that with more intentionality, the ability to have that, is this really in the best interest of the patient? I think we would have more epiphanies than we allow ourselves to have of saying, wait a second, is this really the right thing to be doing?
Based on what you're describing right now, it seems entirely possible, actually maybe even frequent, for there to be a discrepancy between what motivates the surgeon to operate and what motivates the patient to undertake a heroic intervention. If so, how would you recognize when that momentum is more surgeon-driven than patient-driven at that point of care?
Yeah, you're currently in residency, and I'm sure you see a lot of different ways of how people go about this. I think it's both verbal and nonverbal things, those cues. First off, how do you, with a sharp sword in these situations where it's really difficult, we go back to that informed decision. How do I have this conversation so that this patient, I actually believe that this patient understands to some degree what we're talking about here, the ramifications of what it is, and with a sharp sword kind of dividing what the hopes of myself as a surgeon are and what the patient's values are. Let's put an example out there, a pretty straightforward one that I think we've all dealt with to some degree, a big operation on a Jehovah's Witness. That's anemic at the time. There's a patient value that I have to respect, that I have to put this conversation into that context and say, is this really the right thing to do? I go back, the antidote, I think for the question you asked is, how do we recognize when the momentum toward a heroic operation is being driven more by myself as a surgeon than by the patient? I think the antidote, the countermeasure to that is to pull up a chair and listen. And you've been on rounds with me. We have not an infrequent amount of difficult consults at our large hospital system. They're bad infections, they're loser situations, you can't win. But the one thing I do is I pull up a chair and I sit down intentionally at the same level as that patient in the office or in the clinic or in the hospital setting. Because if I stand above them, that automatically kind of puts this nonverbal language of I'm asking you, I'm inviting you into a conversation, but I'm at a higher level than you. When you equalize that playing field with those simple things, now they start to talk. Now they may start to break down. Now they start to bring out the things that you may not even ask. And this is something that as orthopedic surgeons, we never get a lesson on, ever. And just letting that 30 seconds sit, you'll start to get those pieces of information to say, is this really me driving this conversation, or is the patient really on board with this? And yeah, that took me a lot of time to figure out. Going back to that God complex scenario that I had, I feel like we all have as young surgeons. We're trying to live in our own skin, and we're trying to make those x-rays and outcomes look as beautiful as possible, and we beat ourselves up for every adverse outcome. And then eventually you realize, as long as I show up and I give my A+ effort, and I've planned this meticulously, and I've made sure I've prepared and for myself, my body, my mind for this, and it still doesn't go right, I can live with that. And I think that's one of those scenarios that a bit tangential to the surgeon goal, patient goal conversation that you just asked, but it all kind of plays interwoven into this. I think ultimately, if I could leave just like the caveat of this question, even a technically perfect operation, if you haven't taken the time to have a real conversation at a level playing field with the patient, can still be the wrong operation. Sometimes the bravest operation you can do is an operation you never perform. And I think just like kind of putting those two things together and carrying those with you really can be a guiding light.
Let's dive into the conversation piece a little bit more. What does a truly effective conversation look like when you're trying to help a patient navigate the choice in their life-changing moments? How does the conversation look like?
Yeah, there's a lot of hard conversations that we have the opportunity to have in our careers. Certainly in my world, the two hardest conversations that I have are, sir, ma'am, I need to tell you that you have cancer, and all of the part of that conversation that flows from that. And the second broad category of regular difficult conversations that I have is I need to remove a body part, a limb. An amputation conversation. It is unequivocally, and I'm absolutely convinced about this, by far and away the most visceral reaction that patients have is not to the cancer conversation. I've had patients laugh, cry, joke around, walk out of the room on me, do all kinds of things with the cancer scenario. Some people, you can see it in their eyes. Let's go. Let's roll. Tell me what the next step is. You know those people, they have the best fighting chance here. With an amputation conversation, that whole wide variety and spectrum really shrinks to one of two emotions, anger or denial. And it is across the board that people will fight hard against what you're recommending. It takes time. It takes 2, 3, 4, 7 conversations of bringing that patient back and having a conversation with them and trickling it in. Why? Well, I think this is one of the things you just asked is, what does it look like to help this patient navigate one of these life-changing decisions? Well, I think taking a step back and understanding kind of the human psyche, sociology. Like, what can our palliative medicine partners, our psychology partners teach us? First thing, I think in these hard conversations to understand, there's this concept of the golden minute. You have somewhere around 60 to 90 seconds to get out the topics that matter the most. Because when somebody hears bad news, their mind will shut down. And I am very upfront with people. Before I even drop the news, the difficult conversation is, all right, here's the deal. We're going to have some things that really are not pleasant to talk about. Some of these are going to be scary. There's going to be a lot of emotions, and you're going to forget most of what I tell you. I understand that you will walk out of this room knowing only 10 to 20% and be able to regurgitate that. And you have your mom, your sister, your friend, your fiance in the room, whoever that is, and they'll pick up other little bits and pieces of this. And together you may all be able to piece together half of what I say, and that's okay. We're going to have multiple follow-up conversations, but I've got to have this. And then I drop the C word on them, or I drop the amputation word on them. I see in their minds, they're spinning, they're trying to keep up, and then after a while, it just stops. And that's another moment of saying, like, be very real and very intentional about what you choose. And, if I have a brand new cancer conversation, it's usually, this is what your diagnosis is. I do have a treatment plan for you. I have multiple people that I would like to get you in to see. And there are going to be a lot of questions that you're going to want to answer. I can't answer them all right now. I invite you to write them down, and I will go through one by one and either answer them as we go through this journey together, or I will find the right person that can. That's about all you can get out. That took about 60 seconds for me to say. And one, it gives the patient the bare basic information. It lets them know that there's hope, and it empowers them by saying, I have a team that's going to follow me in this. And then that's the same for infection. That's the same for a life-changing traumatic fracture or polytrauma. That's the same for a child with, some kind of congenital disorder that medicine doesn't have a great fix for. You go through that, but you have to understand that bad news oftentimes is really heard with the heart before it's actually understood with the mind. That's really the concept of that golden rule. I think reading the room, it's an art. You walk into that room, and if you have 5 to 10 minutes to see a new patient, you can't really build a relationship with them. But that's the reality of healthcare nowadays, and we have to wrestle with that. I get that. The hand partner that sees 60 patients in clinic and is just churning, doesn't have a time to establish a great rapport because they have so many other people that need them for short snippets of time. But there is this concept of when you walk in, I do survey the room, much like a CIA agent walks in and cases all the exits and the windows and all the points of potential weakness. I do the same thing in the room. And I look at eyes, I look at body language, I look at the person who's fidgeting, who's looking on their phone, whose eyes look like they're empty. I look at everything, and I try to match that room with what do they need. Sometimes it's opening up with a small little joke. Sometimes it's noticing what's on their shirt or talking about a vacation or just establishing something personal with them. That now you have a little bit of that trust that you can then enter into this. So that read the room concept is really important. I think pausing, I mentioned this before, that concept of let the silence work. Just for one moment as a surgeon, pretend that you don't have to fill up every moment with our type AAA personalities with something that we're actively doing, and train yourself that listening is something you're actively doing. I think is a really important thing. We also gravitate very much to evidence-based medicine as surgeons, as physicians, okay? This statistic would say, you have, with a prosthetic joint infection, you have a better chance of dying in 5 years than our top 3 most common cancers in the United States, which is a true statistic. Prosthetic joint infection, it sucks. But patients care more about your tone. They don't want some robot spitting them out numbers that they could look up on open evidence before they walked in the room. They want honesty over statistics. They want somebody who's real sitting in that chair, somebody who actually can sympathize, maybe even empathize, dare I say. That's what they're going to listen to. And I think the other part is we all work as teams. We are going to cross paths with people that can teach us things. In my world, I've learned so many things from prosthetists who can empathize with patients because they are amputees themselves, from palliative medicine partners, of how the art of articulating what you want to talk about with as few amount of words as possible. From patients, hey doc, for the next patient that you see with this, they may want to hear about this, or when you said that, it really scared me. Can we talk about that? You start to actually create this bag of tricks of what to do, what to double down on, and what not to do ever again. And that's kind of that process of finding empathy. So the conversation, how you navigate these, I can't give everybody that recipe that check the box of how you do it, but at the same time, if you actually are intentional about it and kind of go through each of these things and remembering to pull up a chair, the golden rule, to read the room, don't let silence is actually active participant, you follow all those, I think your ability to actually get through and have that patient really share with you what their goals and intentions are and commit with you, not because of you, but with you, is easily able to be overcome.
This is very insightful, and this is a science in of itself. And I guess speaking of other science, behavioral economists describe an escalation of commitment, or a sunken cost fallacy, where someone just keeps investing in something despite continuous losses just because they've already invested too much. How would you personally guard against continuing to operate? Simply because it's technically possible, or just because you've invested so much trying to make a salvage work?
So I think some of the things that I would really just highlight. So number one is take a pause after a major setback. That's what I do. If something didn't go right, just play it in your mind. Go upstairs, just grab a coffee and just think about it. Talk with somebody. I have a partner that I pick up a phone and call sometimes before I even talk to the family. Like literally, hey, I created this whole surgery, this custom cutting guide. It didn't sit well. I couldn't get the screws to go in the right trajectory for the custom implant I made. Yeah, I made it work. I jerry-rigged it. But yeah, it took 2 extra hours and I was really frustrated and I don't love my x-ray. And what can I do differently? What did I change? What could I change? I think that's a really important thing. Again, the concept of you don't have to fill up every moment of time with something active. Sometimes just sitting and thinking in silence helps. I think inviting your colleagues, surround yourself with people that you trust and that you respect. Ask them, what would you do? Hey, and you're going to hear some cool things. You're going to hear some things that, I don't think that's a good idea. Here's why. Have a conversation. But if you have people challenge your thinking before a complication or setback occurs or afterward, you're going to get better. You're going to get smarter at how to talk to people. You're going to get better at when to pull out, know when to fold them, so to speak. And know when to hold them, when to say, yeah, I'm going to double down, we can keep doing this. I think the concept of, I've mentioned this before, but don't be afraid to have a second or a third conversation with a patient or a family member or a colleague or an engineer or whatever that is prior to making these irreversible decisions. These huge decisions that we have to make, taking off a limb, sending somebody to hospice, whatever that may be. Again, remember, there's a golden rule moment. This patient may not have heard everything. You may need closure to talk with these patients, and that will help you kind of understand that, and again, in many ways, create that epiphany moment. I think another small thing, I throw it out there, being an oncologist, constantly fighting for what the value is to a system. You only look at what an oncologist individually bills for a system. It's not that much. When you look at the downstream revenue, it's tremendous because we mobilize systems and multidisciplinary surgical teams and labs and imaging and whatnot. But I actually invited my chair or the leader of our group to visit my operating room several times. And it was strategic, but I'm about to take care of this absolute train wreck. I want you to see what I'm doing when I'm in there for 2 or 3 hours. And the benefit I do by sparing my partners from having to take that on call, from being able to mobilize the system, by saying yes to a patient that's been told no 5 times from 5 other surgeons or hospital systems, and being able to show that this operating room time, while it doesn't show on the RVU or the bottom line margin, is time well spent. It was a huge thing for me to be able to guard against this escalation of feel like I have to keep doubling down on something stupid, because I know that the people that hired me and that lead me believe in what I'm doing. They see the value in it. And I think the final thing, because I'm sure that a fair amount of people on this podcast that are listening to this, we're all trained in our early careers to say yes. How do you build a practice? You say yes to everything. Even if you're a joint surgeon and you have a cubital tunnel come in and you're in private practice in rural Virginia, you're going to say yes to that because you know what? That might come attached to a total knee or a total hip replacement someday. You're going to be a generalist. You're going to do things like that help build your reputation, your notoriety, your quality, your referral base, whatever that is. I think true maturity, though, 5-7 years in the practice, is when you start to begin to say no. You have the guts to have a real conversation with yourself. I don't need to be on that committee. What is that doing for me to get me to this level of the next step that I have, this vision? And just as importantly, a real conversation with a patient. If you are able to say no and live with yourself, that maturity, now you can start to really sit down, feel comfortable in your own skin, pull up a chair and tell that patient, this is what I'm going to do. And I tell patients this all the time. When I tell them no, I will say, if you're a parent, I'll ask them, are you a parent? Generally, most of the time patients will say, yes, I at least know the concept of parenting. And I will say, my job is to prevent you as a child from touching the hot stove, just like a parent does. That child wants so desperately to touch it because it's this curiosity and because they've been told no or for whatever reason. And I know it's going to create harm. And that's what I see this moment as being. And I'll have this conversation if I have another doctor sitting across from me. I'm not dumbing this down. I'm not patronizing them. I'm just trying to put a simple concept of saying, I've been down this road enough to know that if we keep pushing, you are going to either have a devastating outcome or I'm going to make a difficult situation even more miserable. And I want to protect you from that.
So there's a lot of self-reflection, and not just from an individual surgeon standpoint here, but also more so self-reflection at a field level. How do you think, or how good are we as a field at defining or determining success of what we do in general?
Yeah, we're getting better because we're actually starting to ask the patient, in every subspecialty in orthopedics and medicine, it's PROMs, right? Patient-reported outcomes. We're actually believing that it's not how long the x-ray looks good. It used to be all about that. In orthopedics, most of us judge our careers and make our pictures based on what x-rays look like. It's one of the few surgical subspecialties where you get imaging and you can see it immediately. General surgeons can't see that. They sew a bowel together and it disappears. You have no idea what kind of quality went on there. Whereas if I see somebody that does a total hip replacement, within 30 seconds to get into the PACU, I can tell you what kind of a total hip that was. And we translate that to 25, 30 years down the road. That was our definition of success, is how long did that implant last? We have no idea if that patient was actually happy or got back to what they wanted to do, was able to resume work, were able to get back to the athletic activities they want. Now we're actually changing that and focusing on patient-reported outcomes. And I have a partner, Nico Piuzzi, who is an unbelievable wealth of knowledge when it comes to how do we change the game in orthopedic surgery. And he's looking at phenotypical patient-reported outcomes, whereas not only a PROMS, which right now is the PROMIS scores and the SF36 and the Harris hip score, whatever that may be, but now how do I individualize that for every single patient based on a bunch of variables? That is really cool. But you know what none of that talks about is what you and I are talking about right now. And that is really the deeper conversation. We focus on what are the simple things to measure patient success. Do you get back to work? Do you get back to sport? Are you pain-free? Et cetera, et cetera. But you know what I haven't ever seen is somebody to double down and have a really good PROMS for an amputee. Because we feel like we failed. And it's almost like, all right, so that patient is no longer being admitted to the hospital. They're no longer on antibiotics and they're out of pain. But man, they're missing a limb. We're not going to focus on them. But what happens if we did? I bet you would find some of the happiest patients if we started asking some of our most difficult population what they define as success. It's probably also starting with the beginning question to them is asking the patient, what outcome are you looking for that you would define as success? Getting up front, looking at that ahead of time. In the hard conversations, for instance, the third conversation we haven't really talked about is when I have to tell somebody no and say, I think that hospice and really focusing on quality of life is the better of the two options here. And I don't offer that right away, but when I listen to a patient and they say, I just want to be home with my family, I just want some more good days, that is a no-brainer of saying, I can meet you where you're at, get you out of the hospital. I have a wonderful team. Remember that whole concept of empowerment that I'm going to get you plugged in with. And we're going to make sure that you are at home with everybody that is important to you for the rest of your life. That's a powerful conversation to have. And ultimately, again, Ahmed, it all boils down to the simple concept of the patient's definition of success is really the only one that ultimately matters.
And those are a lot of tough decisions that are being made, one or the other. So as a surgeon involved, not necessarily making the decision, but certainly involved in those difficult situations, guilt can certainly exist regardless of the pathway, right? So, you may regret going along with recommending some form of heroic salvage intervention, and you may also regret not pursuing that intervention. So, do you think there's a guilt cycle that develops around these decisions from a surgeon's standpoint? And how have you learned to separate responsibility from outcomes that, quite frankly, you're really never in total control of?
It's a deep question, my friend. I'm proud of you for asking it. Talk about one of those faux pas nobody wants to talk about. We actually have to admit that we're weak, that we're like what orthopedic surgeon is going to admit that they feel guilty? It happens. It's not a common thing because you have to go out in public and actually say I did something wrong. I think there's a few things. Number one is my relationship has changed over the course of time with myself. I am far more forgiving of myself than I used to be. When I'm talking to residents who are about to graduate and I tell them, like, obviously, first year of your practice is going to be difficult, but like it's not just the first year, it's all the things that you have to live with. When you show up and you're a brand new staff, you just have to prove to yourself that you are safe, you're competent, you're able to push yourself beyond what you knew, and then you start to run a second room. And maybe even before that, you start to have your first set of complications. Oh gosh, like I'm no longer invincible. When I'm as an oncologist, you don't have your first local recurrence for at least a year and a half to 2 years into practice, and then they start coming in. You thought you were invincible, and I can't believe all these people that taught me aren't batting 1,000. In reality, it's like to be a really good surgeon, you're going to have complications. A Hall of Famer in the Major League Hall of Fame, they don't bat 1,000 average. They bat barely 300, maybe 330. And that's what gets you into the Hall of Fame. And why are we not more forgiving of ourselves? When you start having to teach somebody in a second room, that's another thing. When you have those two rooms and a surgery is going on while you're trying to finish up in another room, your mind is in two different places. That's another part of maturation. And the final one is dealing with complications that somebody else created for you. Somebody under your tutelage, under your watch. That's a really hard maturation. And how do you live with yourself? How are you forgiving and saying, I can't be everywhere to anyone, and I can't get this wound to heal on somebody that has absolutely no nutrition reserve, even though the x-ray looks fine, and now I'm dealing with an infection and a wound that won't heal with multiple readmissions. Like, how do you forgive yourself? Humility, in my mind, offers incredible freedom from guilt. And I think that's an important thing. Again, talking to a bunch of surgeons that have the similar mindset to myself, that takes time, certainly, when you're young, to start to understand that. I think judging yourself by the integrity of your decision and the actions in preparation is far more important than judging yourself by perfect outcomes. Did I give my A-plus effort? My mentor, Victor Krebs, said this to me all the time, and this is one of those pieces of wisdom I pass down. I show up, every patient gets a minimum 60 minutes of my time in the operating room, even with the simplest operations, and they get an A-plus job from me. Every single total knee, total hip, cancer operation, whatever it is. And I can leave knowing I didn't cut a single corner, so that when a complication occurs, it's not because I didn't show up and I didn't display the integrity of preparation. I think that preparing is certainly something, and it's funny with residents who are listening to this, you keep telling yourself, oh, in medical school I was constantly studying, in residency they were on me if I wasn't preparing and reading the anatomy textbooks and pulling articles. I can tell you I still read probably more than some of my residents. I'm staring at an anatomy program on my computer all the time, not because I don't know it, it's because I just want to refresh it. I want to spin it around and subtract and retract with all the things we can do now, because I know that the single most important thing in the operating room in terms of my confidence, my efficiency, my ability to be a captain of the ship is, do I understand the anatomy? And so that preparing well is a really, really small, stupid thing that seemingly we don't even need to talk about, but I think it deserves being verbalized. And there's a reason why Proverbs calls it the crown of wisdom, is the gray hair, because you truly get smarter as time goes on. Not with how much better of a surgeon you become, and yes, that occurs too, but eventually you plateau. You truly reach a mastery level where a total hip replacement, somebody who's done 10,000 of them, they're probably not going to get that much better. But how you talk to somebody, how you deal with difficult things, there's always room for improvement from now until the day that we retire and then even beyond. So I guess that if I could just leave like this section, you can live with difficult outcomes if you know that you made the right decision for the right reasons and you left everything on the court when it came to both the planning and the execution. And beyond that, you did everything you could, and it's okay to forgive yourself.
Dr. Mesko, this was an amazing conversation. Let's say if you had to distill everything that we talked about right now into one guiding principle, what do you think every orthopedic surgeon should remember when deciding where the limits of surgery really lie?
Man, why don't you lecture on the history of the world? You got 30 seconds, go. I feel like that's a tough conversation or a tough question to answer. I would say this probably. It's gonna distill a bunch of what we talked about, but it's actually the opposite, I think, of where our minds go as surgeons. And it's the great surgeons are not defined by what they simply can do, but by knowing when doing less actually serves the patient more. I think that's what takes you beyond mastery. We've focused so much on surgical mastery. And it may take one person in residency, you could do 5 femoral nails and you got this with your eyes blindfolded, and another person may have to do 50 femoral nails before they actually get enough repetitions where everything just starts to click. We get to that point in our careers of mastery, but we're so focused on our technical skills. I think the next level, we talk about like all the different levels of happiness and all the different levels of, it's not the superficial stuff as a surgeon, it's the next step. And it's when can I actually look ahead, have that proverbial crystal ball and say, the best way I can help you is by offering you something smaller than you had hoped I would today. I think that's probably the guiding principle in this context, this conversation, knowing that judgment is just as important as the technical skills that you've built, you've been blessed with, and you've learned to hone, that if we're not using our minds to hone our judgment and our conversation, like we're selling ourselves short in so many ways. I think knowing the limits of surgery, and we are constantly pushing that. Shoot, we're doing face transplants and we're taking organs out of animals and keeping humans alive. Like we are doing unbelievable things in medicine. But there are also going to be times when we just have to say, I am smarter than this robot. And I know what the limits of this surgery are, not because of the actual surgery, but because the patient undergoing the surgery has some serious things that a spreadsheet or a calculation or a nomogram cannot tell me, because I've been there and I've sat there and I've talked with them. And I think probably the last thing in this guiding principle, again, being that extra level of maturity of knowing when doing less actually serves the patient more, is don't leave the patient hanging. Don't walk out of the room and the last thing that they ever see is your backside. Like, offer, I will walk this journey with you. I will find the right person for you. I will follow up with you on a phone call or on my chart, or let's see each other in 2 weeks, or here's my cell phone number, give me a call. It's a tough thing. And I'm gonna leave, if you're okay with this. Do you have time for a quick story along this line?
Absolutely.
Several years ago, I had a patient with a cancer diagnosis, and that patient had the opportunity to be cured, but it was a big surgery. And there was a lot of social background with some domestic violence and with some difficulties with just paying the bills, financial toxicity before the cancer conversation even crept in. And I was able to get a team together, social workers, like a whole massive team, to pull off a surgery. And she wouldn't follow up for her regular cancer surveillance. And I got pretty frustrated with her in an office visit. And I wanted her to feel the same sense of urgency that I felt. Let's just call her Laura, which is not her real name. But Laura, I need you to understand how important it is for you to get your CT scan, your MRI. Like, this cancer can come back. And there was so many different things in play, but ultimately her and I had a bit of a spat, and I just said, like, I don't know what else I can do for you if you aren't willing to like go and schedule this MRI. We will get this written off for you. If it's a financial difficulty, I have a great social work team here. I had this Jiminy the Cricket conscience moment about a week later of I should follow up with Laura because I didn't leave well with her. I called her out of the blue and she picked up the phone and it was a pretty short conversation. Or she said, Dr. Mesko, I'd like to see you in the office again. Do you have time to see me? And I said, sure. I'll see you in the office. I had an appointment a few days later. So she came back to the office to see me, and we had this conversation. The last thing she didn't see was my backside. What she told me in that office, I don't usually get teary-eyed, but this story kills me every time. What she told me in that office is, Dr. Mesko, when you called me, I had a gun to my head. And I think I would have followed through with it had you not called me. And I wanted to see you to tell you that, but also to thank you for advocating for me. And she still to this day struggles with getting surveillance scans. We were able to get a few, but it was one of the most powerful moments in my career of, again, don't let the last thing that patient sees be your backside if you haven't left it on a good spot. So I appreciate the time and the conversation.
Thank you for sharing that, Dr. Mesko. I mean, overall, this conversation was outstanding, and I think our field needs more of it, not less. Not just how we operate, but how we decide whether to operate at all. And thank you so much for taking the time, and thank you for sharing your expertise and your personal stories.
Well, I appreciate the opportunity and the time and for thinking of me on this, and I hope that this conversation, people can listen to it in sound bites and it will help them.
Oh, thank you. And thanks to our listeners for tuning in. If you enjoyed this episode, just visit AAOS.org/AAOS Now Podcast and follow so you don't miss future takes on these controversial topics in our field. I'm looking forward to see you in the next one.
Thank you for listening to this episode of the AAOS Now Podcast, part of the AAOS Bone Beat Orthopaedic Podcast channel. Production and editing provided by MK Quinn Media. Don't miss out on future episodes of the AAOS Now podcast. Bookmark our page, aaos.org/AAOS-now-podcast. Listen to new and past episodes on Apple Podcasts, Spotify, and the Health Podcast Network, and watch video versions of every episode on the AAOS Now podcast YouTube channel.